Hello and welcome to Sheffield Live. You are watching African Voices with me, Baillor Jalloh. And my guest today is the Director of Public Health Sheffield, Greg Fell. Hi, Greg.
Hi, Baillor. How are you?
I'm good. Yourself?
Good, thanks.
Right. Without wasting much of your time, let's start straight away. Let's start with the latest update on COVID infections in around Sheffield and the new variant present, if the new variant is present in Sheffield.
Epidemiology-wise, I've got data up until just after Christmas. There's a bit of a gap just after Christmas, but I don't think the story's changed remarkably since then. The rates of infection are flat. They were very high up in late September, early October, and had been coming down since mid-October. Towards the middle to end of December, that rate of decline stopped, a much higher rate than we saw in summer. So the rates of infection are around 150 per 100,000 over a 7-day period. So for about 50 cases per day, there or thereabouts, fairly evenly spread across Sheffield, though perhaps slightly more concentrated in the east of Sheffield, and that number's been relatively flat. What we don't know yet is the impact of Christmas. Lots of people will have mixed over Christmas. There's no two ways about that. Hopefully people will careful about it, but we will see. But that will have an impact, and that will start to put the rates up. And I'd expect to see that around and about New Year time. So over the next couple of days, if we're going to see the impact of Christmas and the mixing over Christmas, we'll see that over the next couple of days in cases. Then I think it's probably worth a brief note on hospitals. Hospitals are busy across South Yorkshire. Sheffield is no exception to that. We're not in the same position as the London hospitals. That's a different league altogether. Rates of infection are much higher, by an order of magnitude higher, in London, the South East, and most of the home counties around London, and going up actually. Here we're significantly lower than that, and flat, stable-ish. And also hospitals, though the activity is quite high, a not insignificant number of people with COVID-19 in hospital, and then within that, a not insignificant number of people who are very poorly in intensive care. That's flat over time and slightly going down. It's going down slowly, and it's going down slowly because there are a lot of people with quite complex illness who, in wave one, they wouldn't have survived. Now we've got better treatments and people are surviving, and clearly that's good news. But it means that hospitals remain quite busy. Thus, our room for manoeuvring is pretty slim, actually. I think overall, epidemiology-wise, we're not in a terrible position, but equally, there's no room for resting on our laurels and being comfortable. And our room for manoeuvre is quite limited. Therefore, we stick with the programme for probably the foreseeable future. Last point on epidemiology is the new variant. There will be a bit of it in Sheffield. There'll be more of it than we know about because we don't sequence all of the people who test positive, but there's not much. Certainly, again, most of the epidemiology is telling me that the prevalence of the new variant is predominantly in London and the South East, and that is neither good nor bad news. It is what it is. But looking at the rate of spread, I think it's unlikely that it's not going to spread across the rest of the country. But as we stand today, there's not much of it in Sheffield, though there is some. It's not in itself more dangerous that we know about, but it's more transmissible. So the more people will get it, and of those more people that will get it, some people will have a more severe illness. But the things that make a difference are just the same as the things that made a difference to the old variant, for want of a better phrase. Washing hands, keeping distance, wearing face coverings, limiting social contact. So the control measures are just the same as they were. So that's probably about where we are with regard to epidemiology as of today.
So in terms of what you've just kind of explained, at least that is good news, and we're not to the point where we want yet, but we know that today the health secretary has kind of warned the new variant has made things very difficult to suppress the virus itself. And he, quote unquote, he said it has made it much harder, and there will be a possibility of another lockdown, or Sheffield and other cities as well being put in tier 4. Is that the case?
Don't know. That's a decision that the Secretary of State needs to make. And I think he's making a statement in Parliament sometime this afternoon. He may be making it now. We don't have any forewarning of what announcement Secretary of State will or won't make. My default working assumption is that Sheffield and South Yorkshire will remain in tier 3. If some places in the country are put into tier 4, or there's a new tier 5, that's a decision for the Prime Minister and Secretary of State, and I don't know. I've no insight into how that will work or when that will be announced, but I know there is an announcement today.
But as the public health figure in Sheffield, in your opinion, from what you've seen so far, do you think these restrictions are working?
Yes, undoubtedly. I can't screen share, but if you look at the rate of decline since basically the universities and schools restarted in September, there was a big increase, and that was always going to be the case, actually, and that happened nationally, not just locally. Restrictions were put in place from late October onwards. And the rate has continued to come down and down and down since then. We've been in some variant of either tier 3 national lockdown or the new tier 3, which is slightly stricter than the old tier 3, since let me just think, 24th of October. And the rate of infections has come down and down and down again since then. The caveat, and it's an important caveat, is that then began, the rate of infections over time began to flatline from about mid-December onwards. So two possible conclusions, neither of which is particularly provable or disprovable. One is we've reached the lower limit of what we can expect from tier 3 level restrictions, or secondly, the impact of the lockdown is wearing off, or possibly thirdly, we're all getting a bit sick and tired of it. And that was something that was seen in Wales when there was a fire break, which was essentially a mini lockdown in Wales. Everyone was sick and tired of it. And when the fire break was restricted, when the fire break was lifted, the rate spiked quickly again. So I think we do need to be careful for the foreseeable future, because whilst we do talk about lockdowns and restrictions, and they do have impact, positive, on a level of infection, but also negative. There's social and economic harm that comes with these things. We talk about lockdowns and restrictions, and they have had the intended impact, no doubt. We forget that it remains a dangerous respiratory virus that kills 1% of people that become poorly with it, and 1% is not a trivial number, particularly given how quickly we've seen it can spread.
But if it happens to be either way, we're not going to avoid a lockdown, or the restrictions are getting harder every now and then, why is it not possible now rather than later?
Well, why is it not possible to have a lockdown now rather than later? Mm-hmm. I'm not, given where we stand today, 30th of December, I'm not convinced that the epidemiology supports a full lockdown and all of the economic harm that goes with it. The caveat I'll put on it is that none of us yet know what the impact of Christmas will be. So Christmas might send the rates rising quickly. And so the two or three key variables to be watchful for are overall 7-day rate of infection per 100,000, which at the moment is fairly stable. If that begins to change, go upwards or preferably downwards, but it's likely to go upwards, how quickly it goes upwards, and a kind of a gently rising curve is perhaps of less concern than the very steeply rising curve. And the rate of infection in the elderly, who are the group that are most likely to become very seriously ill, and hospitalization rates, which is one of the pinch points in the system, because the thing that we're trying to avoid is hospitals becoming absolutely full, that they have to actually suspend planned other activity, which also has consequences, as we've seen. So those are the 4 key metrics, and at the moment we're in a relatively stable position. And whilst it's not my call, it's the Prime Minister's call, I'm not sure the epidemiology would support the local version of a full lockdown. It is dynamic. I've seen in one town in the north, they've tripled their rates in the space of about 3 or 4 days. So that can change pretty quickly, and we keep a pretty close watch on it. But at the moment, it's probably not warranted.
So let's talk about vaccination here. We've seen today the UK's medicines regulator approving the Oxford AstraZeneca vaccine. Your reaction to that?
It's amazing news, undoubtedly amazing news. So people talk about game changers, and you know the availability of the Pfizer-BioNTech vaccine was definitely a game changer. The key problem was logistics. It had to be stored at -80 degrees, and there aren't many fridges that keep things that cold. So that limits the speed with which you can get through the vaccination program. The Oxford AstraZeneca vaccine handles a bit like the flu vaccine. You need to keep it in a normal vaccine fridge, and the cold chain is pretty similar. The way it handles is pretty similar, and we'll probably treat it like the normal flu vaccine program, which means you can dramatically increase the speed at which you get through the vaccination program. So the Oxford AstraZeneca vaccine definitely is a game changer. There's no doubt about that. It is great news. I still think it will probably take us a couple of months to get through a full population vaccination program. You know, we're starting with the very elderly, particularly those who are in care homes. That group of people are at highest risk of death. It's dead right to start with that group, but eventually we'll get down to everyone over 65 and everyone between, I think it's 16 and 64 who has a long-term condition, and then some other groups. We'll be vaccinating significant chunk of the nearly 600,000 people that live in Sheffield. I think it will still take us a couple of months at least to get through those, though we will be pulling out all the stops to do that as quickly as possible. So the availability of the AstraZeneca vaccine does change the game because it dramatically increases the speed with which we can do it.
So is it going to be the same process as the Pfizer-BioNTech vaccine? It will have to be 2 vaccination periods?
Still a 2-dose thing. I'd need to check the sheets. You'd think I should know these things offhand. I think it's two doses 10 days apart, but it will be on the MHRA website. So it's still 2 doses, and you're not fully immune until after the second. It's actually 10 days after the second dose. So 10 days after the second dose, you'll be considered to be immune. But between first dose and second dose, and immediately after second dose, you're still not fully immune, and we still need to take care. And even if you are fully immune, you can still carry the virus on your hands. So one of the most common routes of transmission is someone sneezes on a surface, I touch the surface, then put my hand to my mouth. So whether you're vaccinated or not, you can still transmit the virus that way. So I still think we'll need to be careful, because there still will be people who won't be vaccinated.
Thank you for clarifying that. So in terms of both vaccines, both the Pfizer-BioNTech and the Oxford AstraZeneca vaccines, will there be any side effects to it? And if there is any, what are the things to look out for?
Yeah, I suppose it's important to be clear. All vaccines come with side effects, and let's not pretend that vaccines don't come with side effects. I suppose the thing to consider is that the side effects are relatively minor, and I'll come on to the specifics in a minute. Versus the risk of severe illness from COVID is actually quite significant, particularly as the older you get. So we were all in the business of trading off the fairly small risks with the fairly significant chance of a significant illness. But there are vaccines, and the most commonly reported side effects that were in both the Pfizer and the AstraZeneca study were site-specific stuff. You know, the way you stick the needle into someone's shoulder. It's quite common that people report soreness, muscle soreness, stiffness of arm, that kind of thing. There's just common with someone sticking a needle in your arm. It tends to be pretty transient, tends to be a couple of hours, day maximum, and it certainly is nothing much to worry about. Often also reported were flu-like symptoms a few days afterwards, and that's certainly often reported with the flu vaccine, and it has been reported in studies with this, with the COVID vaccine. It's not COVID. It's physiologically impossible for you to acquire a COVID infection from either of the two available vaccines, because they're not live viruses. It's just the physiology and the biology mean that it can't be COVID. It might be COVID that you've acquired from somewhere else, and it just happens to be coincidentally timed with the needle going in your arm. But the vaccine itself can't give you COVID. It's just biologically impossible. The third thing to worry about is allergic reaction. There was a very well publicized series of allergic reactions middle of December from memory, all of which were managed entirely appropriately. All of the people who had the reaction recovered well. They were all people with known allergy histories. I think they all carried EpiPens with them. And allergic reactions happen. They're very, very rare, but they do happen. Hence, there's a requirement for a short observation period after the needle has been, after the injections happened. And those who are doing the vaccines are very well trained on what to do should someone have an allergic reaction. But it's very, very, very rare. The reason it gained such prominence in the media just before Christmas was that there were a few of them that happened all about the same time, and everyone's on hyper alert for side effects. But they do happen. There's no doubt about the fact they do happen, but they're rare and can be very well managed. Beyond that, I've seen no reports of any significant side effects that would trouble me at all. I'd very happily have the vaccine, and I will do when my time is up.
Good. Let's talk about the other concerns here that the public does have apart from the side effects. There are many people across Sheffield and across the country, for some reasons of one or another, including religious people who have concerns about the ethical of using these vaccines. What will you say are in these vaccines to make it clear to people who are still skeptical about using these vaccines for religious reasons?
So I suppose there's porcine content in the AstraZeneca vaccine. I don't think in the Pfizer vaccine. I may be proven wrong on that one, but there is porcine content. There's a porcine stabilizer in the AstraZeneca vaccine, as there is in the flu vaccine. And the two key religious bodies, the Muslim Council of Britain and the Jewish leadership bodies, both said repeatedly with regard to the flu vaccine, the risk of severe illness with flu outweighs the religious concerns about use of porcine content. Please be vaccinated against flu. I've not yet seen the equivalent statements with regard to the COVID vaccine, but I can't imagine that either the Jewish leadership, the Jewish leadership bodies or the Muslim leadership bodies are going to say anything different with regard to the COVID vaccine than they do the flu vaccine. So I think, again, it's a sort of, people need to make their own decisions, and people need to make their own informed decisions. The religious leadership bodies, I think, will say you should have this vaccine, and the risk of severe illness is not trivial, as we have seen. So, but I can probably do little more than to reassure people that it's safe, it's effective. I'm not in a position to comment on the ethics or the religious issues associated with the porcine content, but the religious leadership bodies have, or they have with regard to flu vaccine, and I'm pretty sure they will with regard to the COVID vaccine.
Okay, let's talk about the other concerns here, even though you've said people should make up their minds. But at the end of the day, you are the public health figure here, a person that is that people consider to be the expert that should clarify things when they are in doubt. But looking at social media, there are many videos circulating online via WhatsApp and Facebook where people are kind of giving out conspiracy theories, talking about depopulation agenda. Is there any truth to that? Can you just clarify?
No. When there's any new vaccine, or even with well established vaccines, there are always many myths, hoaxes, pseudoscience, false science, or misinterpretations of science that are put out on various forms of social and other media to suit particular views and particular ideologies. Being brutally blunt, most of it to all of it's rubbish, utter rubbish. I would recommend that people only get their information from sources that are gov.uk sources. And to be fair, the Public Health England website is pretty good. Or again, to its credit, the BBC website is pretty good. Those are the only two places that I recommend people go to for information. I mean, there's myths and falsehoods that are all over social media. People can and will choose to believe what they want to believe, and me nor anyone else can control that. All I can say is I strongly recommend people who are invited to get a COVID vaccine to get a COVID vaccine. It's effective, it's safe, and it will protect you or provide you the best protection from severe illness or worse.
I think the difficulty here is because some of these videos that are circulating are people that claims to be doctors or experts within this country and some other parts of the world that are saying the government is hiding things. So how difficult for you as a person, as a public health director in Sheffield, especially for someone like you, when you see other people, like, I won't say your colleagues, but people who claim to be in the health industry circulating videos like this, saying, look, there is a different agenda to these vaccines.
I've seen examples of UK registered healthcare professionals circulating videos on social media and otherwise that promulgate falsehoods. I tend to call them out quietly. I tend not to do it with great fanfare because, as a great colleague of mine once said, going toe to toe with an anti-vaxxer will just end up giving more oxygen to a falsehood and a myth than it warrants, and that in itself can sow doubt and sow confusion in the minds of people, and do harm in the process of doing that. So personally, I rarely, if ever, will publicly call out anti-vaxxers, and there are many people who are anti-vaxxers, and they have and will and can do significant harm. But I won't call them out in public because doing that creates oxygen, and that can cause more confusion, not less confusion. But I will call them out privately, and have done and will do when I see it. They tend to avoid me because I tend to call them out. But when I see it, I'll call them out privately. And I've seen it done in this town. We've done so quietly and privately, not publicly, and I've seen it done in lots of spaces. I mean, the most famous example was the Andrew Wakefield MMR publication in the Lancet, which to overly simplify it, the intonation of Andrew Wakefield's original paper in the Lancet was that MMR gives you autism. It was utter rubbish. The Lancet later, admittedly much later, retracted the paper and said it was wrong and it was false research, and Andrew Wakefield was struck off the medical register. However, he still practices as a doctor in the USA, and I can't do anything about that. So I know there are people out there who put out false information with the premise of sowing doubt that this vaccine or any other vaccine has saved lives. But the science is pretty clear. Vaccinations save lives. It's the single most effective public health intervention next to clean water globally. And this vaccine will doubtless prove to be the case. We don't know that. We've got the science we've got to date, but I'd be amazed if the science turns out wrong on this one. And we keep a very close watch on it.
And let's talk about one more concern before we move on, and that is the length of time that it took to develop this vaccine, because there are many people as well out there arguing, saying, look, it's been years and years. There is no vaccine for AIDS. There is no vaccine for cancer and that kind of thing. How on earth, within a year, that a COVID vaccine has been developed? And also, is there any race to this? Like, let's say, is it more effective on Black people than white people, or is it more effective on white people than Black people? Because there are so many conspiracy theories here, where I've seen even a video as I'm talking to you, which I could show you on WhatsApp, that says that are encouraging Black people not to take it, that it is a way of killing Black people. So what will you say to those sort of videos?
But it's killing Black people is wrong. It's just wrong. It's bordering on criminal. It's certainly a utterly false statement. We don't know whether or not it's any more effective in black people than white people. I don't think there's the data available there to demonstrate that one way or the other. But black humans are really rather like white humans in many respects, other than the colour of their skin. I can't imagine there's any science to support a notion that the vaccine, this particular or any other vaccine, is any more or less effective in white people or black people or people of any other race or ethnicity. The WhatsApp message that you referred to, I'd love to see it, but it's wrong. It's just it's a falsehood. It's plain wrong. On the question of this was developed quickly, and why was it developed this quickly? There was a beautiful piece in the Guardian about 2 or 3 days ago, actually, and I'll kind of pick it out in a minute. But 10 reasons why we got COVID vaccines so quickly without cutting corners, and people might want to look it up. It was very good. It was very clearly stated, and I'll just pick on a few of them. One, the plans to develop a mass vaccination program with support from industry and academic institutions was already in place a long time before the COVID pandemic broke upon us. Secondly, China identified the novel coronavirus pretty early on. Remember the days when we called it the Wuhan virus? They seem that seems a long time ago now. And they'd sequenced it. They'd done the genetic sequencing really quickly, and that speeded up the vaccine development process inordinately. Substantial funding was granted immediately. There was no questions, no qualms, no academics spending months writing grant application process. Governments underwrote the vaccination program and the costs immediately. The clinical trial process was speeded up massively. No doubts there, and the trials started pretty much straight away. I think there were trials underway in March, April at the earliest. April at the latest. There were significant numbers of volunteers, and the regulatory process was speeded up. So quite often what happens is that the regulatory process is quite long and doesn't start until the phase 3 clinical study data is available to us. The regulatory process undertook what's known as a rolling review and took the data as it was available from the vaccine manufacturers and or the academic institutions. That speeded up the regulatory process no end. It is fair to say that it does normally take 6 years more from the identification of a novel bacteria or virus to getting a vaccination for that microorganism. This took a year from it being sequenced through to the point of a vaccine that's got regulatory approval. But because of all of those things that were put together, that speeded that up no end. On the question of why isn't there a vaccine for cancer? One, there is. HPV, human papilloma virus, causes cervical cancer, and there's a vaccine available for it, and it works pretty well. Secondly, beyond HPV, cancer is not caused by a virus, it's caused by mutations of cells. You can't develop vaccines for those things.
Pretty clear there. Let's move on. Schools are meant to be returning next week, but there are suggestions for it to be delayed, as we've seen in other parts of the country. What's your take on that?
We'll see what the Prime Minister says this afternoon, or Secretary of State for Health, or Gavin Williamson says this afternoon. I think for Sheffield, as we stand now with the epidemiology is pretty similar to what it was when schools were open towards the back end of the Christmas term. I think I'd be perfectly happy for schools to be open. I accept that's not a completely that's not a statement that's accepted by lots of people. Most virus transmission isn't in schools, it's in homes. Most transmission events are in homes for a number of reasons. We spend most time there, our guard is off there. They're the least clean places. I don't spend loads of time in my house cleaning down the touch points in my home, whereas in schools they do. And schools, to their credit, have moved heaven and earth to make schools as safe as possible and to kind of manage the risk of transmission. And as a result, we've seen very little in-school transmission. There has been some, but not much. And most of the transmission has been staff to staff in the staff room, not the classroom. Again, when guard is let down and over the boiling kettle, etc. So I think as the epidemiology stands now, I think I'm very happy if schools open, but Secretary of State may make different decisions. We will follow government policy. If government policy is currently that schools should be open on the 4th of January. I have heard that may be delayed by a week, but that will be government policy. That won't be my policy. That will be government policy, and we'll follow government policy.
And looking at the vaccine as well, there are also suggestions for teachers or school carers to be placed under the priority people. Would that something you recommend as well in Sheffield?
No, we'll go with the priority ordering is set by a national scientific committee known as the JCVI, the Joint Committee on Vaccination and Immunisation, and just they've published a revised ordering today. I'll never find it now. But we start with the very elderly, and then there is health and social care staff, and I'll come back onto that. And then we go down the age cohorts to 65, all those 65 and above. And then there's people 15 to 65 who have a long-term condition is the next on the list. The aim of the vaccination program is to prevent death. The healthy adults aged under 60 are a vanishingly small chance of death. I think someone said to me the other day, there've been about 400 over about now 67,000 deaths have been in healthy under 60 year olds. The reason why we are prioritizing NHS and social care staff is to keep the NHS and social care system running firstly, because it not running has other consequences, because there aren't enough doctors to treat people who've had heart attacks, and there'll be deaths on account of that. And secondly, to prevent healthcare related transmission, which is a significant concern, particularly in care homes, for instance, where we've seen once a care home has COVID in it, it gets through the care home pretty quickly, and people do die, and that's something we all want to avoid. So we remain focused with our priority ordering on vaccination to prevent as many deaths as possible. The teaching staff who have underlying illnesses will be prioritized when we get to adults aged 16 to 64 with underlying illnesses, but probably not before. But again, government may change its policy again, and if it does, then we'll follow government policy.
And you mentioned earlier that you don't have the data at the minute in terms of what happened in Christmas, and we know the restrictions were eased on Christmas Day. Yeah. Now we've got New Year coming, and as you will know, during normal times, people will be moving up and down. But this year, according to government guidelines, we shouldn't be doing that. So what would be your message to the people who will be watching your interview today, or to Sheffielders across the city?
So same as it was for Christmas. I mean, we're in tier 3, and that limits the number of it limits the number of places we can go, and it limits the number of people we can mix with. People may choose to ignore that. Those. That is breaking the law, but people will mix. Christmas, we were enabled to mix by government policy, that isn't in place for New Year. As per before, limit the number of people that you have social contact with, because whether you call it bubbles, whether you call it the rule of 6, whatever you want to call it, the more people you have contact with, the more opportunity there is for you to acquire the virus and spread it through your social network. So yeah, New Year will be different. I'm looking forward to New Year 2021, to be honest.
Right, Greg, thank you very much for your time. I believe all the questions that you've answered here today are crystal clear. Hopefully, people watching your interview today will learn a lot, and to the viewers as well. Thank you very much for joining us. That was African Voices from me, Baillor Jalloh, and we had the Director of Public Health Sheffield, Greg Fell. Thank you.